So carpal tunnel is a very common disease nowadays, and we see a lot more patients turning in with pain in the wrist and median nerve problems because people are spending a lot more time on computers, iPhones, iPads, their handheld devices, and it's a lot more of these cases we see in the last 5 years. Especially the younger population is affected more than it used to be 10 and 15 years ago. So what we see the problem in addressing carpal tunnel is that people don't miss the window of opportunity to manage their carpal tunnel with conservative care, with the proper physical therapy. And the reason being is that the patients feel the nerve problem like numbness, tingling, wrist pain, and because it's a nervy feeling, they think they need to see a neurologist. And although neurologists are not completely wrong doctors to see, and the reason they're not totally wrong, but they're also not totally right, or they should not be the only doctors in this case, is because the neurologists use diagnostic tools that are called nerve conduction studies and muscle EMG. And these are electrodiagnostic tests that provide diagnosis what is the injury and exactly the amount of the injury. But it doesn't tell you what causes the injury. And in the recent 5 or 10 years, with the development of high-resolution ultrasonography, the ultrasound is actually replacing electrodiagnostic study or becoming a complementary. In a way, these two modalities, the electrodiagnosis and the high-frequency ultrasound, are complementary to each other, and the diagnosis should be formed by both. So as a physical therapy practice, as a rehabilitative practitioner, we use diagnostic ultrasonography. I've been doing this for 10 years. I have high resolution, one of the top machines in the world, and it helps us tremendously to address the patient who has a carpal tunnel that hasn't been going on for many years. So I'll show you what details we can see on the ultrasound and how it helps us. So if I come up to the distal forearm, I can see the median nerve. And if I go down with my probe, I can see the median nerve comes up and it's going to curl around the tendons here, the flexor tendons. And as I go more distally to the wrist, it's going to come into carpal tunnel. And how do I know it's a carpal tunnel? Because I see this bone on the left and this bone on the right. I know we're already in the carpal tunnel. And this structure is the retinaculum, wrist retinaculum, and the carpal tunnel is actually a collection of structures. So it forms a tunnel because it's situated, the median nerve travels through the bones medial and laterally, and it's closed by the retinaculum on the top. And if I tilt the probe, I see all the tendons, flexor tendons on the bottom. So the ultrasound allows me to see what causes this carpal tunnel, what causes the medial nerve compression. So if I had to do electrodiagnostic study, I actually don't know what is the cause. But here I can immediately trace the ulnar nerve within the contents of the canal or carpal tunnel, within the contents of the tunnel. I could trace all the tendons, muscles, and see what causes the impingement. I can measure the nerve. And the measurements play an important role in diagnosis as well. Now, another advantage of the diagnostic ultrasonography is that I can move. Like if you do an MRI, it's hard to assess carpal tunnel as well as an ultrasound because the resolution is much lower. But another advantage is on the ultrasound we can move the wrist, and we could see the gliding of the median nerve versus the ligaments that's on the bottom. So these are the tendons. These are the tendons, the flexor tendons, and the median nerve is right on top. So if I move the wrist, I can see that the nerve glides one way and the tendons glide the other way. So oftentimes there are adhesions between these two structures, and that's when we do hydrodissection procedures. So how do we address carpal tunnel in a physical therapy perspective? So we address the muscles of the forearm because these muscles send the tendon down the carpal tunnel. We do the dry needling, we release the trigger points, we do some soft tissue work to normalize muscle tone here. We refer patients for hydrodissections where they free the nerve and its adhesions. We mobilize the carpal bones, and occasionally we do neurostimulation. We connect a couple needles close to the nerve and we modulate the nerve with the current. So in a mild to moderate carpal tunnel, physical therapy could be extremely successful to alleviate the symptoms and could keep the symptoms down, can cure the symptoms if caught early enough, and can be very successful to postpone the surgery for years. Thank you very much.